I can't believe we've made it to 2017 in the BrainWaves podcast. Our 40th episode aired last week. There have been thousands of downloads from all over the country and the world. And if you want us to change the way we do the podcast, or if you have suggestions for new topics, let us know by contacting us on our blog at brainwaves.me, or emailing us directly at bweditorialboard@gmail.com. Also, keep an eye out for Neurocritical Care Society's official podcast. It's set to debut later this spring, and I'm helping them produce it. Be sure to check it out. For now, we'll move on to the theme of our show on BrainWaves this week. And hint, it concerns meningitis. But first, a word from our sponsors.
This episode was powered by Paul Hodge, a financial planner who works specifically with medical professionals. He has helped members of the BrainWaves podcast grow their wealth and manage risk. Learn more about how to secure your financial future at paul-hodge.com. A 59-year-old actress presented to your urgent care clinic with 5 days of progressive headache. She had taken off work the preceding 2 days due to such severe symptoms. The headache began insidiously, was associated with photophobia but not phonophobia, and nausea with vomiting this morning. It did not improve with NSAIDs or sleep. She tells you her headache has been associated with neck pain and stiffness as well as generalized fatigue. She came to urgent care this morning because of new diplopia, which she confirms is binocular, present in the horizontal and vertical planes, and gets better when she tilts her head backward and to the right. She denies any prior history of headache, vocal neurological deficits, recent illness, sick contacts, travel, tick bites, pets, or new medications. She has a history of well-controlled diabetes, not on insulin, and cold sores. No family member has ever had prior symptoms, and there is no personal or family history of autoimmune disease. Her mother had breast cancer. On examination, she is uncomfortable but in no acute distress. Her general medical examination is only remarkable for the absence of fever. Her neck resists passive flexion. The neurologic exam is notable for a complete third nerve palsy on the left and partial sixth nerve palsy on the right.
We're not going to spend a lot of time going through the differential diagnosis here. Diabetes is a risk factor for infarction to the brain parenchyma and to the cranial nerves, and stroke can present with headache in a small proportion of cases, but symptoms are not progressive or insidious as in this patient's. A history of herpes may suggest an HSV-1 encephalitis, but she lacks a fever and patients often present with altered mentation or seizures. In the absence of any other pertinent past medical history or family history, it's most likely that our patient has developed a subacute meningitis. For starters, we should all have a basic understanding of meningitis, which is an inflammation of the CSF and the meninges. Not to be confused with encephalitis, which is an inflammation of the brain parenchyma, but sometimes you can see a meningoencephalitis, in which there is brain and meningeal inflammation, or even crazier combinations like encephalomyelitis, where there is brain and spinal cord inflammation, sometimes seen in varicella zoster, listeria, or autoimmune conditions, or even a meningoencephalomyelitis. The meningitis are usually categorized into bacterial and aseptic, but calling meningitis aseptic is technically a misnomer. It literally means not septic, which means not infective or infectious. But many of these cases are infectious, and most identifiable causes of meningitis are viral. More specifically, aseptic meningitis indicates a meningitis not caused by a bacterial infection. So the differential diagnosis can be frustratingly broad, but in most instances, thankfully, it heralds a more favorable prognosis for the patient than a bacterial cause. Our patient likely has an aseptic meningitis given the subacute clinical course. In contrast, a bacterial meningitis often evolves over 24 to 48 hours, and the patients look sick. I mean really, really sick. They're febrile, they can be hypotensive due to bacteremia, and they will look extremely uncomfortable. They can be pretty altered or even comatose. The in-hospital mortality rate is 1 in 5 among patients who are treated for bacterial causes of meningitis, but if it's untreated, it's usually fatal or results in irreparable neurologic deficits. The exception to this acuity seen in bacterial meningitis is when Listeria is the responsible pathogen. Listeria can cause a meningitis, a meningoencephalitis, a rhombencephalitis, myelitis, or a central nervous system abscess, but when it causes a meningitis, the clinical course is slow and it's progressive, evolving over several days. It more often affects neonates, the immunocompromised, and the elderly, patients over the age of 65 typically. So these populations are empirically covered with ampicillin or trimethoprim sulfamethoxazole until Listeria is excluded. That being said, our patient's clinical course is not typical for a bacterial pathogen, nor is this patient all that susceptible to listeria. So an aseptic meningitis it is. But before we get into the differential diagnosis for aseptic meningitis, let's talk about how the diagnosis of aseptic meningitis is made. Clinically, patients often present with a headache, photophobia, neck stiffness, and many other constitutional symptoms like fever, vomiting, fatigue and rash, myalgias and arthralgias. Seizures occur, but they're more frequent in pediatric cases and in cases of meningoencephalitis, as you might see in HSV-1. Cranial neuropathies are uncommon but not unheard of, especially in cases of fungal, inflammatory, or carcinomatous meningitis, in rhomboencephalitis, and less commonly in viral causes of meningitis. And many of these findings you'll appreciate on the exam. It's important to get the LP early and before antibiotics if possible, in order to increase the yield of identifying a bacterial or fungal pathogen. In rare instances, this should be delayed in order to obtain head imaging. Experts recommend a non-contrast head CT before the LP in patients with suspected intracranial hypertension with mass effect, focal neurologic deficits, age greater than 60, seizures in the past week, or immunodeficiency. So consider these elements when an urgent LP is needed. Once you get the LP, features suggestive of an aseptic meningitis are white blood cell count greater than 10 per cubic millimeter with a negative bacterial culture. That being said, a pleocytosis is not necessary to make the diagnosis, and white blood cell counts may be normal in up to 20% of patients. A white blood cell count greater than several hundred or thousand would be more consistent with a bacterial cause of meningitis. An assumption I've seen frequently is that aseptic meningitis produces a lymphocytic pleocytosis. However, it can be neutrophil predominant in over half of cases. The CSF protein is often elevated in aseptic meningitis, but only mildly so. Protein greater than 200 mg per deciliter would be less consistent with most causes of aseptic meningitis, except for things like tuberculosis or carcinomatous meningitis, and it can also be seen in cases of spinal block. The glucose is often normal in aseptic meningitis, or close to normal, except in cases of TB or other fungal causes where hypoglycemia may be present. A large number of red blood cells, which do not clear in tube 4, or more specifically xanthochromia, can be seen in subarachnoid hemorrhage, which can masquerade as an aseptic meningitis, and it can be seen in HSV encephalitis or meningoencephalitis as well. Once these preliminary results come back, you may consider more targeted testing. So let's get back to our patient. Because she does have focal deficits, a stat head CT can be performed before the LP is obtained, and we should get some routine blood work as well to make sure it's safe to get the lumbar puncture.
Laboratory data is notable for a hemoglobin of 9.8 mg per deciliter, platelet count of 233, calcium of 11.3 mg per deciliter, and a serum glucose of 215. Her INR and PTT were within normal limits. A non-contrast head CT was unremarkable for any acute pathology. An LP showed an opening pressure of 29 centimeters of water, so 30 cc's were removed. Her closing pressure was 18 centimeters of water. The CSF was remarkable for 2 red blood cells and 128 white blood cells per microliter in the fourth tube, 73% of which were lymphocytes, a protein of 110 mg per deciliter, and a glucose slightly low at 35. Gram stain and HSV PCR were negative. Cryptococcal antigen was checked because of the intracranial hypertension, and it was negative. AFB stain was also negative, but an AFB and routine fungal cultures were sent.
First of all, it is fair to check for HSV-1 and HSV-2, even in the absence of encephalitic features on exam or imaging, because either can cause an acute meningitis and not just encephalitis, and HSV-2 has been associated with the chronic syndrome Mollaret's meningitis. Among viral causes of meningitis, HSV-1 and 2 are among the few we can pharmacologically treat, the others being HIV, varicella zoster, and lastly CMV in immunocompromised hosts. You should know that meningitis secondary to HIV occurs during the acute phase of seroconversion, unless the patient has AIDS, in which the meningitis can be caused by many opportunistic and non-opportunistic pathogens. However, among these and all the remaining identifiable causes of aseptic meningitis, enterovirus takes the cake. And enterovirus is still the most common identifiable cause of meningitis, regardless of the patient's age. According to the 2006 PICNIC study, enteroviruses accounted for 85 to 95% of identifiable culprits responsible for non-bacterial meningitis. In addition to testing for enteroviruses by CSF PCR, Testing for EBV is routinely performed in suspected viral cases. Depending on travel history and exposures, which our patient has none of, you may also test for West Nile, St. Louis encephalitis, tick-borne encephalitis, or the lymphocytic choriomeningitis virus if they've been exposed to rodents. Each of these viruses can cause a meningitis, so I'll want to know the patient's HIV status, both PCR and antibody screening, check VZV and EBV from the CSF, and obtain a gadolinium-enhanced MRI of the brain in the meantime in order to exclude mass lesions of the midbrain and pons, as well as to exclude rhombencephalitis.
Serum HIV PCR and antibodies were negative. VZV PCR was negative. The ratio of CSF to serum VZV antibodies indicated prior immunization and no active intrathecal antibody synthesis. An MRI confirmed mild to moderate ventriculomegaly with transependymal flow and diffuse pachymeningeal enhancement without any obvious underlying structural parenchymal lesion.
I guess this isn't too surprising, given the clinical story and the exam which is notable for multiple cranial neuropathies. We were eventually going to proceed down the fungal, inflammatory, or malignant route. But before we get there, let's at least acknowledge that our patient's symptoms are not likely related to a drug-induced aseptic meningitis. By far, ibuprofen wins the prize for being the most common cause of drug-induced meningitis, and that's probably because it's taken like candy. Other NSAIDs, IVIG, trimethoprim sulfamethoxazole, and intrathecal chemotherapies have been implicated in drug-induced aseptic meningitis. But when medications are responsible, the imaging is often normal, and certainly wouldn't look like this patient's. And patients also wouldn't present with cranial nerve palsies. So we've got to move back to the things that our patient could have. Let's consider some of her diagnostic testing so far. CSF hypoglycemia, or low CSF glucose, is observed in cases of fungal, tuberculous, and carcinomatous meningitis, all of which can pick off cranial nerves individually and produce a radiculopathy from subarachnoid invasion of the spinal cord, or they can cause a communicating hydrocephalus. Sarcoidosis, idiopathic hypertrophic pachymeningitis, IgG4-related disease, granulomatosis with polyangiitis, lupus, and several other inflammatory/autoimmune/rheumatologic conditions can cause a pachymeningeal or leptomeningeal enhancement, along with infectious and carcinomatous causes. So I'd like to see if the lab resulted the AFB and fungal cultures yet. Looking back on some of the other labs, notably the hypercalcemia and anemia, I would also image the chest, abdomen, and pelvis for malignancy or for sarcoidosis.
Her AFB and fungal cultures were normal. A CT scan of the chest, abdomen, and pelvis showed a simple renal cyst on the left, but no other mass lesions or lymphadenopathy. Incidentally noted were several 1 to 3 centimeter lytic lesions of the right eighth rib and 3 thoracic vertebral bodies.
In the absence of an obvious cancer on this detailed scan, the scattered lytic lesions in conjunction with the prior anemia and hypercalcemia are highly suggestive of a metastatic cancer or multiple myeloma. The primary site of a solid tumor with lytic bone lesions could be thyroid, renal, hepatocellular, melanoma, and tumors arising from the adrenal gland. It would be of low yield to send the remaining CSF from the first LP for cytopathology at this point, because the cell viability falls quickly after CSF sampling. Plus, given the communicating hydrocephalus on MRI and the elevated initial opening pressure, you're probably going to get a repeat lumbar puncture a few more times during the course of the patient's hospitalization in order to relieve that pressure. In addition to repeating the LP for opening pressure and cytopathology, I would add flow cytometry since multiple myeloma is on the differential. And for that, I would also send a serum and urine protein electrophoresis with immunofixation to see if there's an associated paraprotein.
The CSF cytopathology confirmed the presence of cellular atypia, and cytometry identified a clonal population of plasma cells consistent with a diagnosis of myelomatous meningitis. A serum protein electrophoresis identified an IgG kappa paraprotein.
So there we have it, myelomatous meningitis, also known as CNS myelomatosis. This is when you call the oncology and the radiation oncology consults, and then you have to have a difficult discussion with the patient. Patients with carcinomatous meningitis have a life expectancy of about 3 months, and the 6-month survival rate for myelomatous meningitis is 7%, according to some data. Whole brain and spine radiation have been shown to prolong survival in these patients from an average of about 3 weeks to 3 months, and that kind of time can be invaluable, but the quality of life may not be worth the effort to some. Neurologic manifestations of multiple myeloma are numerous, and they can be related directly to the plasma cell disorder, its treatment, or its downstream consequences, things like hypercoagulability, hypercalcemia, lytic vertebral lesions with pathologic fractures, and so on. Most often, multiple myeloma is associated with a motor-predominant distal demyelinating polyneuropathy, seen in between 5 and 50% of patients. In the central nervous system, there are only a few main complications. You can get cranial nerve involvement with extension into or irritation of the dura, intraparenchymal myeloma lesions rarely, and in less than 1% patients may develop a myelomatous meningitis, as in the case of our patient. So, it's a terrible disease, but we arrived at the diagnosis using a meticulous approach, weighing the pretest probability of each diagnostic test as we performed it, and incorporating the results into a parsimonious explanation for our patient's aseptic meningitis. I hope you all enjoyed this exercise today. That's all for BrainWaves this week. I'm Jim Siegler. I'll talk to you next time.
Thanks for listening to BrainWaves today. If you like what you just heard, you can find more related material on the web at brainwaves.me or find us on Twitter at brainwavesaudio. Feel free to contact us at bweditorialboard@gmail.com. Be sure to check out our iTunes archive for older episodes. This episode was produced by Jim Siegler. Music by Lee Rosevier. I'm Erica Mejia. Join us next time for another edition of BrainWaves.